Hello, good morning.
Good
Good
afternoon.
afternoon, by
Good
the way,
afternoon,
in Germany.
Carlos.
Hello, Carlos, Mario, and Chuck.
Great. Hi, Mario. It seems that you guys are hearing me well and the pictures are okay, right?
Excellent. Yes.
Okay. Well, I don't hear very well. Williams, can you take care of that? And while you do that, I would like to quickly introduce my colleagues here. On my left side here, we have Rodrigo Costa, who is going to do the case. On my right-hand side, Sergio Braga. We are doing a challenging PDA case. So let's move to the first slide, please. Next one. So this is a 30-month-old boy weighing, it's not 14, it's 10 kilos in fact. He's very symptomatic with recurrent pulmonary infections and failure to thrive. He has a big heart on the x-ray, you're gonna see that. He's on furosemide, and he has a continuous heart murmur in the left upper sternal border and bulging pulses. Next one. The echo showed a PDA shunting left to right. Gradient across the PDA was 55, a very enlarged LV. He had a cath done at another institution about 3 months ago, which showed aortic pressure of 82 over 33, MPA 35 over 17. We found different numbers here, you're going to see in a minute. And they did an attempt at closing the PDA due to the tubular shape. So this child was referred to our institution. Next one. So this was the first picture that they got. Kind of type C ductus, tubular shape. They measure about 5. We measured more than that. Next one. So this is a steel frame. You can better appreciate the anatomy of this PDA. Next one. So we intend to close this PDA with the new Occlutech ductal occluder. This is a new device. It hasn't been approved in Brazil. I guess it does have CE mark. It has a disc on the left side, and on the right side, the shank is larger on the pulmonary end. Next one. For those who are not familiar with this device, and I have to admit that this is our third case. We did more simple cases before. It has 3 diameters. You can see that on the screen. D1 refers to the skirt, the retention skirt. D2 refers to the aortic end of the shank. And D3 refers to the pulmonary end. And as you can see here on this drawing, D3 is larger than D1. So this is different than the usual Amplatzer device, the ADO, and the CIRA device. Next one. It does come in a variety of sizes. It has 2 lengths, about 2 to 3 millimeters different, the standard PDA device and the long PDA device. The measurements, it starts at 3.5 and goes all the way to 4, 5, 6, 8, 10, 12, and 14. I've talked to Mazini Aoi over the net, and I think they are about to publish their first experience with this device on 45 patients.
Carlos.
And you should pick up a device that is 2 millimeters larger than the aortic end, than the minimal diameter of the ductus. Yes?
Right. What is the measurement of the duct? You said 4 millimeters, 5 millimeters, or maybe more.
Let's go to the pictures. I think it's more, Shaq. What we found here, in regards to pressure, we found aortic pressure. Can you turn on the aortic pressure? Pressure. 90 over 33 with a mean of 55. We had, in the pulmonary artery, we have systolic 54 over 24 with a mean of 34, so significant pulmonary hypertension. The QP-QS was 3:1, so significant shunt. The LVED is 20, which gives us a pulmonary vascular resistance less than 2 units.
Okay.
If you see the pictures, I think it's on the screen right now.
Carlos, can I just ask
measured
the audience
the duct,
here? I'm just going to ask the audience here some questions about this duct and devices. So Zahid, first of all.
I was wondering, initially he said the gradient is 55 across this tubular ductus.
That was in the other lab, apparently.
No, the other lab, the echo.
Oh, on echo, sorry. Yeah.
Okay.
So, Zahid, anatomy and what device?
The device he's choosing is a duct occluder device.
Yeah. What would you use?
In this scenario,
Yeah.
he can use whatever the Occlutech or PDA device.
Okay.
Implants.
Alejandro, is that? Yeah.
Yeah. Hi, Carlos. I think that this type C
Hi, Alejandro.
PDA,
Saludos.
I agree that you can close this with an ADO. One, you can close with a PDA R device, and you can close with the Occlutech device. I would go with a device that is 2 millimeters larger than the minimal PDA diameter.
Okay, Ingo, what would you use in this anatomy?
At first I thought an 80-0164, but maybe that's too large on the aortic side. So my alternative would be to try to put in a 5-4-80-02 additional sizes, not a normal 80-02.
Okay, 80-02 additional size. Abe, there you are, you keep moving around.
Right. I would use
Yeah, hold on, Carlos.
a device which is 2 to 3 millimeters larger
So
than the diameter of the duct.
80-01, 80-02, 80-02 AS, what?
ADO1 or that type of device they have now.
All right, Carlos, carry on.
Yeah, no, just let me ask if Mazini is in the audience, or Ziad, because they do have some experience with this device. or
Ziad
Tarek.
isn't, and Mazni is not, and Hasri, I saw him earlier, but I can't see. Hasri, are you here? No, so none of the names you asked for
Yes,
are here.
I'm here.
Who is
Where?
there?
Oh, there you are. No, where? At the back.
Who is there?
Yeah, the
Yeah,
back.
Hasri, you're
Yes.
hiding at the back.
Is this
Yeah,
Tarek?
I think this is the type of PDA that, of course, we now use the Occlutech. Normally, the size we choose is about 2 mm, larger than the inverse diameter, which is on the aortic side.
Okay. So, Sachin, I think you've got light on.
Yeah. Any other projections for the duct?
So,
See the length?
Carlos, do you have another
just-
projection
Yes,
at all
we
of
do
this
have
duct?
another projection, RAO. This is a little bit, it's more LAO. It's about 100 degrees lateral. It didn't help that much. And we do have RAO projection here.
Okay.
But we got the same measurements.
Okay.
This is 40 degrees RAO.
So,
Okay,
Carlos, just a
and
second.
we got about 5 to 6 millimeters.
Okay, 5
the
to 6
minimal
millimeters.
diameter. So it's a pretty large
Okay.
PDA.
Let me just
Yeah.
ask Joe
5 to 6
Giovanni.
millimeters.
Joe,
Yeah. Hi, Carlos.
you've seen the two projections.
Hi,
You've got
Joe.
the measurement of around 5 to 6 millimeters. What device?
This is a big patient. I would think an AGO1, probably 10.8.
It's a 10 kilo baby.
Just that.
10 kilos. Oh, no, it was a
Or maybe an
Yeah,
8.6
10
then.
kilo baby.
8.6
If it's a young
ADO.
child. I came in late, so
Yeah,
sorry about that.
yeah.
Yeah.
All right.
Yeah, I
Alison.
think if you're getting a measurement of 6, hello, Carlos, anyway, 10.8 should be fine. Maybe an 8.6 will do it.
Carlos, I think you already decided what device you used. You showed the device before this discussion, right? Is that the Occlutech device
Yeah,
an
Occlutech.
advantage
Well,
because of the different shape?
Yeah, well,
in the
in
sense
fact-
that the distal portion is larger
Yeah,
than...
the-
Yeah, it's probably
Exactly,
better
Mario,
in this
exactly.
particular case because apparently it's a long and large tubular duct with no restriction to the pulmonary end. Is that the choice? Is that the reason for your choice?
Perfect, Mario. You got the point here. The only thing, of course, I'm not that experienced with this device, So that's why I was looking for some advice from the more experienced operators such as Ziad, Amazini, and Tarek, because although it does have a larger pulmonary end, which is good for this specific patient because of pulmonary hypertension, and I think it will fit, I was in doubt with regards to the size. So we picked up a device that is 8 millimeters on the aortic end, and it is 10 millimeters on the pulmonary end. Okay, but the problem with this device, I said it wrong. It's 8 millimeter on the aortic side and 10 millimeters on the pulmonary side. But the problem with this device, it has a disc which is 16 millimeters in diameter. So I think maybe it's going to be a little bit big to the size of this child. The other option we have is 6 on the aortic side and then 8 on the pulmonary side. And then we would have a 13 millimeter diameter disc. So we're going to try to put the larger device in and see how it fits.
Well, but theoretically,
we'll change for the other device.
Yeah,
okay?
the aortic part or disc of the device is flat, yes? It's not going to obstruct the aorta.
Not much of ampulla.
However, the disc is flat, but the aorta is not flat. The aorta is a cylinder, isn't it?
Yeah, the aorta.
So you can achieve a compromise, but the two anatomies or two morphologies are not matching each other perfectly. In any case, yes.
Carlos, hey, this is Aid. I was wondering if you're going to put this 10 device with a 13 diameter on the aortic side. What's the diameter of the aorta itself? That is very, very important, because if the diameter of the aorta is tight, you will develop some narrowing there, right?
Yeah, as you can see on the screen, you have the markers. No, let's go back to the screen, guys. Let's go back to the screen, yes. You have the aorta.
So
the markers are 10 millimeters.
So 10 millimeters.
We had measured, it's about 12 millimeters, the aortic diameter, Zahid.
Okay, so that's the circumference is 30.
So the device 36. That we are going to try, it does, sorry?
The circumference would be 36, so.
Say it again.
The circumference of the aorta will be around 36 then, right? So you are going to cover 13 millimeters of the circumference of the aorta if you put a 13
Not
millimeters.
13, 16.
Whoa.
This device has a retention disc diameter of 16.
So that is
the aortic end is 8 and the pulmonary end is 10.
That will cover almost 50% of the circumference of the aorta. That's a very large device for the patient.
Yeah, let's see how it behaves.
So there are a couple of questions.
Let's try this device. Let me show the device first.
Okay, Franz,
now,
quick
can
comment.
we show the device?
Oh, we've got wraps. All right, Franz, do you want to ask your question? We'll then transmit it to Carlos when we link up.
Carlos, this is Franz Freudenthal from Bolivia. We have these large devices in La Paz, and what we do is we take the device in the hand and try to do it smaller, like the ductus, and you're going to see that retention disc going to be also smaller. That means if you take the large device and you fit in your fingers and you put it together, and the distal disc reduced to, you have really a smaller retention disc that you think. I can explain really well. It's clearly what I mean. If you have the device inside the ductus, the retention disc going to be smaller because there is no joint fixation point on the top. Okay, he's doing that.
Well, we'll find out in a second. Okay, Carlos, can you hear us? We lost connection with you.
Yes. Yeah, no. I was just, that's a good point, Franz. So Rodrigo is doing the case. He's going to bring everything back. Everything back, and slowly pushing the retention disc out. Yeah, and bringing everything back at the same time.
So make an onion
And
shape.
while he does that, he's going to push the skirt.
Magnify,
Yes.
magnify.
Bring everything back. Yes. Back, 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 back. Yeah, just a second now. Let me use our reference here.
Are you
Just a
able to
sec,
magnify the image
Rodrigo.
at all, Carlos, or is that the maximum magnification?
Yeah, we can do that in a minute. So just step on the pedal. We have magnification for you. Just bring everything back. More, 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 a little bit more. Can you feel some resistance? Now go back with the pigtail. Let's see how that, a little bit back. Tá pronto para a injeção?
The disc isn't flat,
Era
is
para
it?
deixar pronto. Vamos lá. Now a quick injection here. Inject. See, I think it's too big.
Yeah.
Próximo faz 15, não 10.
That was exactly my point, that it is almost 50% of the circumference of the aorta.
Franz, what were you going to say?
Yes, if you can configure a little more the device and push again the aortic wall, the posterior, then maybe you get a better configuration of the device.
Franz wants you to flatten the device.
Yeah.
Only to try to do it.
Yeah, it's not flat at all, as appears on the table outside the body. Is that right?
Yeah.
It's confined by the aortic wall.
Yeah,
really.
lots of tension here.
I think on the RAO there was a suggestion of posterior indentation of the aorta.
Exactly.
So we have to be careful here.
Exactly, because the disc outside the body is flat. But if it is too large and be put into a cylinder, which is the aorta, cannot be flat anymore.
Yep.
Vai.
That looks bulky.
How does it look like, guys?
It looks bulky on the lateral view. You might have to have a look on the RAO. You might want to change the pigtail to end hole
Can take
catheter
some
and do some
pressure
pullback.
measurements. Cuidado aqui. The other option we have, we might use the other one.
Yeah, Hassan.
While you're holding the device, would you try with a balloon to flatten the arterial disc?
The problem there is that if the device is constrained, even if you use a balloon, it will go back to the shape that it's taken.
Also note you have a lot of pull on the device, so when it's let go,
it'll go back.
It is going to push even out more so.
Yeah.
I think it's a little too big.
Yeah. So
Colleague, what do you guys think?
Yeah, Oliver?
Yeah, I mean, I don't think I'd be too worried about this child's pulmonary artery pressure. I mean, he's symptomatic from left ventricular failure because his LVEDP is very high, and that's flow. He's not got pulmonary vascular disease.
No.
So as soon as you put a plug in, his PA pressure is going to drop.
Susanna.
Yeah.
So I don't think you worry about that.
No, we're worried about the size of the device as inside the aorta.
Yeah, but he seemed to be wanting to use a larger device because he was worried about the PA pressure.
Oh.
And I don't think that's necessary. I mean, I think, use a sensible sized device and the
Ingo.
PA pressure will get better.
So
I think the device is definitely too large, but you can now measure the smallest diameter of the device in this position. And can you tell us the diameter there?
Okay, Carlos, did you understand that?
No, I missed that.
Ingo was suggesting measuring the narrowest point of the device and then perhaps going down a size.
Marcelo, vem aqui rápido. Me mede o
Okay, whilst you're doing that,
dispositivo no
Zahid?
menor diâmetro
I would
dele.
suggest that
Tá do lado
he
da
would
horta.
try to use a 8.6 device. If he uses even M-Plus or 10.8 device, the disc is still
What
going
is
to be
that?
16.
Yeah.
So 8.6 device will be my choice here.
All right, there's a
Or
question
trying
or a
it.
comment over here.
Yeah, Robert Chen, I'm from Halifax, Canada. Carlos, I just wondered, with this kind of a device, do you really need to oversize it at all? I mean, given the configuration and whatnot, would you not just say that it's 6 millimeter duct and put in an 8.6? Or even a smaller device? Is it even necessary to oversize?
Well, the risk is embolization, isn't it? And embolization is more likely in this one to occur into the aorta. Yeah. Okay, so Carlos, what do you think?
Maior do lado da artéria pulmonar. You can see on the screen, Marcelo got almost 8 millimeters, which is the diameter of the device we choose. So there's not much of compression. So we chose 8 by 10. No, it's less than that, Marcelo. So we do have about the same measurements of the native device. So there's not much of compression, and which makes me a little bit afraid to use smaller devices, but we can give it a try.
Carlos, do you want to measure the gradient?
We don't have Amplatzer devices in the house. We have the Cira device, which is similar to the Amplatzer device. We can use if we need.
Do you want to measure the gradient at the moment?
Muscular VSD device.
Yeah, that's what I was suggesting to you, Carlos. Would you consider to use a muscular VSD occluder in this case? Because you have a tubular duct with no constriction, maybe more stable, maybe safer, at least theoretically.
I agree, Mario. That's why we have. Yeah.
Okay.
What size of muscular VSD device would you use, Mario?
Well, probably the 8 millimeter.
But the left disc is going to be 16 again.
Vamos ver pressão.
With an 8 millimeter. It is going to be very protruding in the aorta.
Let me show you the pressure.
Yeah, but...
Hi, guys.
Okay, hold on. Carlos, carry on.
Let's see the pressure. Pressure, aquele lá, aquele. Ou esse aqui, pressão.
Carlos, tell them we don't need to see your face.
Esse screen aqui.
Yeah.
Yeah. So we have ascending aorta about 90, the systolic pressure. Can you pull everything back, Rodrigo, at once? Come.
Can they do picture?
About 85, 88. So we have 2 millimeters of gradient across the aorta.
Okay. All right, just hold it there, Carlos.
So
Gareth, what do you want to say?
Yeah, just looking at if you were thinking of putting a smaller device in here, and that lateral angiogram, I think there's actually flow underneath the device, so I don't think the waist is constrained at all. I think putting a smaller device in it, the central portion isn't going to be big enough, so I think the only other option is a muscular VSD occluder.
Yep.
Yeah, I mean, and probably this the tissue is very distensible, isn't it? I mean, the measurements you are taking it's got a relative value because it's probably very dilatable.
Carlos, it's possible to rotate it, the pigtail, and maybe with this rotation of the pigtail, you get a better configuration of the device?
So, Carlos,
rotation of the pigtail. Why would we have a better configuration of the device?
Yes, because you push this part to the side, and maybe it looks in your label. When you look the box, you don't see it bulky. Try to get it like you make the pictures of the device. Only to try to push with the pigtail this to the right position. This was my first recommendation. I think that the choice of the device is very, very good. If some possibility to try to put it together?
Let me tell you something, Shaq.
Yeah.
That's my impression. We have lots of experience with the Occlutech device with ASD closure, right? And the left disc, when we start, it's a little bit bulkier than the Amplatzer and the Cira device because it does not have the central pin, right?
Yep.
So this PDA device does not have the central pin either. So it takes some time for the bulkiness of the left disc of the ASD device to shrink. And I guess, that's my rough guess, I'm still learning with this device, it's going to do the same. So I suspect that the left disc is going to be, the profile of the retention disc is going to be lower, maybe if we wait a couple of minutes and maybe tomorrow. What I like about this device, I think it's compressed in the middle, not that much.
Well,
and
Carlos.
it's not protruding that much to the aorta.
Okay, so the protrusion is not causing any serious or significant hemodynamic
Coarctation.
effects, right?
Is there a gradient?
If
No.
I
Agree.
there is no gradient, and so it's not very nice to see, but not so bad.
Okay,
So
Carlos,
the
can you
most
just
worrisome, your worries is that the device will embolize, right, when releasing, yes? If the main issue is this, unless you want to change the device, what I could do in this particular case is advance a snare and over the wire, the attachment of the wire to the device and snare the attachment point and then release the device. So
Carlos,
you can test if the device is stable or not. If it is not and embolize, you already snare it.
Carlos,
did you get it?
What do you want to do?
Embolize to the aorta? No, I think, let me see, Rodrigo. I think we should release the device, and I don't think it's going to go anywhere.
Yeah.
It does have some nice pinching. Let me see.
No. Carlos, I don't know whether you want to change the pigtail to NIH or some other catheter so that you can do pullbacks without having to fiddle around with guide wires or what?
Yeah, maybe. Let's take another picture here. Before release the device.
One other advantage I see of this device is that the screw is actually sticking out of the device rather than like the ADO1.
Yeah, damn right.
So this would be easier to snare.
Tá pronto? Tá bom. Já tá. Tá bom, ó.
Yeah. So what do you think? What are you thinking, Carlos?
I have
No,
one.
I think we should release the device.
Yeah. Okay.
Carlos, I know that you don't like so much my comments, but you know I'm crazy. Why you don't take a really small catheter with a really 0.14 and you cross the device from the left side before you release and try to compress to this bulky part to go in? You think it's possible or it's impossible?
No, if you want to compress it, Franz, then you put a balloon across that, rather than fiddle around with a wire through the device. Put a balloon in the aorta and compress it.
Okay, or something like this, but a balloon is more expensive than 0.14 wire.
Well, I think Carlos can afford a balloon.
Shaq, you want to ask some people? I mean, I think he should change this device to a smaller device.
No, I think this is quite a tough one. Just out of interest, and I remember yesterday's discussion, here it's not as clear cut as yesterday.
That the pulmonary pressure.
Go on, Carlos, yes.
The pulmonary pressure is 44/10 with a mean of 27.
Yeah.
So it came down a bit, 44/10 with a mean of 27. And I don't think this device is going to embolize to the descending aorta. There's lots of gradient now. And remember, we have about 10 to 11 millimeters on the right side.
Okay,
so
just
I think
out
we
of
should go ahead
Carlos,
and
just
release
out
the
of
device.
interest, before you do it, just out of interest,
Yes.
hold on a second. Just out of interest from the audience, who would release the device now? Who would not release it, retrieve it, and replace it with a smaller? So it's 50-50, I'm afraid. You'll have to phone a friend. Carlos.
Call me, Carlos. Phone me.
Okay. So, yeah, thank you. Well done.
So we release the device. Let's take the final picture here. In fact, I did like how it's seated within
the
the
device
PDA.
is not going to embolize. It's got a good constriction. Now just measure the gradient and some angios.
Vai, injeta. Yeah, you see how it's flattening out already?
Yep.
Like I said before. So I think we have a good result here. And
Could you do an angiogram in the other
MESNI
projection as
data, this was, yeah, of course. These larger PDAs, larger than 4 millimeters, they have a tendency to close later on. You have an immediate closure rate of about 50 to 60%, and then on the following day about 80%, and sometimes these larger PDAs with this device, they take about 6 months to close completely after endothelialization. So, tá pronto? So I'm giving you RAO view, injeta.
Okay.
Do you ever see hemolysis with that amount of residual shunt early?
Good question. Carlos?
What was the question?
Alison's asking you if you ever see hemolysis with this degree of shunting.
Not really. As I said before, I don't have that much experience with this device yet, but based on Mazzini experience on 45 patients at a median age of 2 years, none of the patients who had very large PDAs, they had about 16 patients, they had hemolysis.
Okay.
Even having this degree of residual shunt just 5 minutes after the procedure.
Carlos.
So I don't think we're going to have hemolysis here.
Okay. Carlos.
It does have fabric inside, the PET. Yes, Shaq, go ahead.
We have 1 minute. Could you do a very, very, very gentle pullback and tell us what the gradient is, if any?
Yes, let's move forward. Let's move forward.
And then we'll finish with you.
There you go, there you go. So let me get the hydrophilic wire.
How are you going to do
Let
a
me
pullback?
give you a pressure, just some flushing here. Eu quero ver aquele lá, ó. Eu quero ver aquele agora. Aquele lá. The screen. Screen, I want to see the screen, guys. Yes. We have ascending aorta. We have 70. Can you record? Grava. Grava. Pode parar. 70. Cadê o hidrofílico? Mudar. Vamos mudar para... Cuidado, cuidado. Quanto eu estou? 83. Vê lá, vê lá. Espera só pouquinho, Rodrigo.
That's a different sort of pullback, but never mind. Okay, it's a sort of pullback gradient. But,
Same pressure. Vamos mostrar?
Okay.
Vou mostrar ali. Mostra a pressão. Same pressure, guys.
Okay.
Big screen, same
we
pressure.
see that.
We had 70, so there's a bit of amplification. So good hemodynamic result, and I think this patient will be fine, Shaq. We are done here.
Okay, Carlos, thank you very much. We'll come back to you later on for the next case. Well done.